Good morning, everybody. Good afternoon to others. Thank you so much for taking the time today to come to our 1 year at Deep in Canada and our series today titled International Lessons for Tackling Health Inequities. And today we have our guest speakers over the pond, Susan Smith, Caroline Mitchell, and David Blane. So I'm just gonna start us off doing a brief overview of Deep in Canada, our 1 year since it had launched, and then have our guest speakers start. So, healthcare, primary healthcare at Deep in Canada. Little background of what our mission has been and continues to be, and what it looks like for our members and what they have been expecting and receiving in terms of help and resources. So our mission here, Deep in Canada, has been advocating for addressing health inequities in primary healthcare from the individual level to organizational and policy levels through the collection of and use of social determinants of health data and the sharing of these ideas and projects. For our members here Deep in Canada, we have collected a network of primary healthcare teams, including health professionals, researchers, patient partners, with whom we have some here joining today, and also decision makers, all working with patients who may face social and also economic disadvantages. And so with this here at Deep in Canada, we've really established a bunch of resources and tools and even coaching and advocacy opportunities that we provide for our members here. For materials and resources, demographics and social needs and data collection. For our coaching is really to support clinic priorities and their health equity initiatives. And with our meetings throughout the last year, it's really what has been to discuss challenges and strategies with our sites across Canada. And a little highlight of our last year since we launched, we've really expanded our membership to 13 organizations. And within these 13 organizations, these represent 25 individual clinics. And we also have our 5 patient partners. And from all of these spread across 8 different provinces: BC, Alberta, Saskatchewan, Ontario, Quebec, Newfoundland, Nova Scotia, and most recently, the Prince Edward Islands province. These also include within these organizations and clinics family health teams, hospitals, community health centers, community pharmacies, provincial health authorities, and research teams. And since launching, we've continued to scale up the use of our Spark tool across the various primary care settings in Canada. And we have implemented more than 25 implementation and research resources for providers and clinics, patients and the public, and also with our Deep in Canada members. And with this, I would love to pass it off to David, one of our guest speakers today.
Great stuff. Thank you, Aaron. I'm going to attempt to share my screen here. I mean, that's just, really impressed by everything you've achieved so far in 1 year. Well done to all involved. Okay, so I've got 10 minutes, and I'm going to give you 10 minutes worth of lessons from 15 years of the Scottish Deep End project. And there's a little bit of background, and just really kind of so we're all on the same page in terms of what we mean by health inequalities or inequities or indeed health disparities. Sometimes the language used changes in different parts of the world. But essentially, we're looking at differences in people's health across the population and between specific population groups that are systematic, avoidable, and unfair. And this impacts most directly on people's potential to fulfill their kind of right to health, physical and mental health. And just to flag that there's clearly various axes of inequality or disadvantage, and sometimes these can intersect. But in Scotland, certainly our biggest issue is socioeconomic disadvantage. And that's most of what the Deep End work in Scotland is based on, although clearly that there are other issues that we try and touch on and address. Another way of thinking about health inequalities is shorter lives lived in poorer health. We see 10 to 15 year differences in life expectancy, between our most deprived and most affluent groups, we see worse than that 20 to 25-year gaps in healthy life expectancy. And this is an illustration of that. You can see for people with multiple long-term conditions or multimorbidity, this is 3 or more. There's a 10 to 15-year gap here between the most deprived decile in the red versus the least deprived, the most affluent in the blue. And then the other kind of big driving force of the Deep End project in Scotland has been the inverse care law. Inverse care law, coined by Julian Tudor Hart over 50 years ago, states that the availability of good medical care tends to vary inversely with the need for it in the population served. So this graph, again, breaks down the Scottish population into deciles of socioeconomic disadvantage. And you've got 2 measures of ill health. The blue line is premature death. The red line is a combination of physical and mental comorbidity, so usually suggesting greater complexity. And then we have more or less a flat distribution of resource, whether measured in consultations per 1,000 patients in green or in funding per patient in black. And we've updated this graph, that was from over 10 years ago, but we've updated it quite recently. And actually, the situation is even worse. So we now have fewer GPs, fewer non-GP clinical staff, and fewer non-clinical staff in the most deprived practices versus the most affluent. And that that graph was the foundation of the Deep End logo, basically flipping it on its side, turning into a swimming pool metaphor with practitioners in the Deep End not only struggling to address the levels of unmet need and medical and social complexity, but also struggling to keep their own heads above water and dealing with stress and burnout. That was then translated into the flag. And one thing to note about the flag is the flagpole is meant to look like a spurtle. For those of you unfamiliar, spurtle is a traditional wooden instrument for stirring porridge. So the idea behind that was that this was an advocacy or an agitating project from the outset. Where are Deep End practices? Well, you can rank every practice in Scotland. There's roughly 900 now, based on the percentage of patients who live in the 15% most deprived postcode areas. And the Deep End is just an arbitrary cutoff of the 100 most deprived. So a couple of things about this graph. One is that there's quite a considerable difference, even within the Deep End, between an 80% practice, like the one I'm sitting in right now, and a 40% practice, like the one I worked in a couple of years ago. There's a qualitative difference in the complexity and the intensity of the work. The other thing to say is that most patients, families who live in the 15% most deprived areas are not registered in Deep End practices. Only about a third are here. The other 2/3 are spread out across other practices in Scotland. So we're really trying to move away from a kind of Deep End practice, slightly exclusive focus towards being more inclusive and thinking about principles of inclusion health, really, that can be applied anywhere. I'm going to say a little bit about these 4 areas of work, these 4 areas of activity around workforce, education, advocacy, research. I know that Caroline and Susan might pick up on these as well. And just a kind of another 4-letter acronym, which is RAMP, because this is kind of about the how and flags the sort of the drivers of the motivation that might help to attract a Deep End workforce, focusing on relationships, autonomy, mastery, and purpose. The issues affecting Deep End communities will be familiar to all of you, but just to kind of highlight the Scottish context and the UK context of over a decade of austerity, benefit sanctions, cuts to services, largely borne by more disadvantaged areas. All these other issues, drugs and alcohol, child protection, vulnerable adults, higher prevalence of just about every non-communicable disease, just a few mentioned here. And we have much higher migrant health populations, higher interpreter consultation rates, none of which have any additional funding in Scotland, at least. I've mentioned the life expectancy before, but one of the kind of results of that is that we see the impact of bereavement at a young age, impact that has on families and communities. We know quite a lot about deep end consultations. All this stuff, more problems to discuss, higher consultation rates, shorter consultations, lower enablement, often poorer outcomes, and higher stress. And that's, I guess, that's the sort of context for the Deep End project, and I think probably Deep End projects internationally. And just very briefly, since 2009, we've achieved a fair amount, although you've done most of this in 1 year. It's 15, but we've got to the stage of managing to have a presence, a profile, a voice, and start to be able to attract resources. So all these projects here, community links workers, welfare advice workers, alcohol nurses, all of those have been Deep End pilot projects. And I think most of them should be available to read about further on the Deep End website. Home straight for me now, and it's just to pick up a bit more about the WHERE acronym. So the workforce, one of the big challenges has been erosion of GP numbers across the board over the last 10, 15 years. And we see that not only in Scotland, but across the other nations of the UK. And I expect it's not too dissimilar in Ireland as well. Over and above that, we have the inverse care law as well. In education, we try and think across the whole career spectrum, and we've been involved in initiatives supporting widening access to try and boost undergraduate teaching in relation to deep end practice and inclusion health, postgraduate training, and lifelong learning. We've tried to support advocacy with media training, with letters to MPs, practice patient level petitions for various topics. And on the research front, just very briefly, I know Caroline's going to say more about this. I'm pleased to say that we now have a Deep End Inclusion Health interest group within our Society for Academic Primary Care. We also have one of our biggest health services funders in the UK, the NIHR, has started to support Deep End research, but possibly more importantly, across all of its grants and fellowships, they now mandate inclusive research design to be considered and explicitly funded within any grants. And I've put here one of our more recent Deep End reports. We're now up to 43. This was about strengthening continuity of care, but really just to show that we're not only trying to support academic research, but also the power of practitioner experience often collected through roundtable discussions, which can be written up and circulated much more quickly. Okay, this is me onto my penultimate slide. And I just wanted to flag one of our, I think, success stories has been around policy impact within Scottish primary care and starting to get the principle of proportionate universalism integrated into some of our policy making. In a nutshell, proportionate universalism is about targeting resources with an intensity that's proportionate to need. So the sort of the equity picture here, rather than the one-size-fits-all picture here. And we've got one recent example of that is called Inclusion Health Action in General Practice, which I can share some links about in the chat afterwards. And it's focused on 3 different themes around inclusive engagement of patients, around enhancing the workforce knowledge and skills, and around enabling proactive outreach and extended consultations. So just to finish up from me, summary of key lessons: inverse care law manifests as a lack of time and resource in disadvantaged areas to adequately address needs. There are various particular issues in deep end practices, just to mention a couple: trauma-informed care, missingness, and to really address these, we need protected time for professional and service development. We need extended consultations and relational continuity, particularly for patients with multiple complex needs. We need integrated care via multidisciplinary team meetings And for all the additional staff that we've started to see in practices here, community links workers, financial advice, they need to be embedded and really made to feel part of the team on a relational basis rather than just co-located. Related to that, for engagement and access challenges, we need more proactive outreach approaches. Team well-being has been key for most of the deep end projects. Mechanisms for sharing learning, both within practices and between practices, and capacity for advocacy. So the idea of having, for instance, a health equity lead in each practice, I think is an interesting one. And then finally, greater involvement both of our patients' communities locally, but also of other advocacy groups, other networks, and also the next generation of staff. So that's me, a bit of a whirlwind tour, and this is just to show some of the flags. I think you might see the slide again, and I realised when I did it that the Deep End Canada wasn't on this one. As you can see, we're having kind of new flags to add pretty regularly now. I think we're across 20 new projects across 4 continents. And I will stop talking there. Thanks for listening and look forward to the Q&A.
Thank you very much, Joe, for putting my slides on. I'm Caroline Mitchell. I'll stop my video just in case there's any problems with people with their sort of videos and stuff like that. I'm a professor at Keele University and I was co-founder of the Deep End Research Alliance in Yorkshire and Humber. Could I have the next slide, please? We've already talked about what workforce education, advocacy and research, but this sort of framework was developed with the launch of the Yorkshire and Humber Deep End network. And there were probably about 90 to 100 people there, all stakeholders, patients, community practitioners, talking about what mattered to them. So workforce and education, we need the best doctors working in the deep end with people with the most complex needs. Advocacy is everybody's business. And I picked up the baton with Liz Walton to lead on research. Next slide, please. Thank you. So we talk about the inverse care law, which we're all very familiar with, but rather less is made about inverse research. And the problem with inverse research is that there is underrepresentation of those same underserved groups in clinical research. And Julian Tudor Hart is most famous for his inverse care law, but he was also a dedicated, really well-trained researcher who went to the Welsh Valleys, one of the most deprived areas, becoming post-industrial as the mines were starting to be closed and the steelworks. And he was dealing with a population which lived in poverty and also had greater health needs and premature death. So he rolled up his sleeves. His wife was a practice nurse, and they set up research practice and became part of a national network of the MRC research practices. Now, general practice was really the poor relation of hospital research. So this was a kind of really innovative, difficult thing to do. But I think Hart realised that if underserved populations aren't included in research, healthcare treatments and care pathways just won't work as well. And nowadays, though, unfortunately, there's been systemic academic neglect. Lots of clinical trials where researchers have convenience sampled people who look and sound like them. So we have this bias towards Eurocentric complex interventions designed with and for people with high health and digital literacy, and our patients get left behind. And in a universal healthcare system where we fund all of those complex interventions, there's another layer of discrimination that's just stuck in the system. And Ryan wrote about this when he described this as hard to reach in research and healthcare was a truism as part of the system of denial that even the best intentioned have constructed around the unpalatable realities of race and class. We'd simply decided that whole sections of the population shouldn't and couldn't be involved in research. So we decided in Sheffield and South Yorkshire that we'd try and prove that wrong. Next slide, please. And we did that for a number of reasons. We think there's lots of benefits for deep end practices because research active organisations retain staff, they develop staff, and you bring resources in that can actually help train and develop staff as well as improve patient care, because we know that patients who participate in research, especially clinical trials, have better outcomes. And we've pulled together lots of research over the years since 2016 that's been developed with and by practitioners and patients. Fair Steps is one example, and you can click on that, or we can send you the links afterwards. But we asked the question, what can primary care do to address health inequalities? And we came up with a series of vignettes based on evidence of hardworking, deep-end practitioners and health equity focused researchers who really tried to make a difference. And we're now working with health economists, and actually a lot of these interventions are cost effective and health equity generating, what we call the win-win situation. And there's a paper that's hopefully soon to be published relating to that. We know that there's a long way to go because primary care is the core relation of the hospital research sector. Next slide, please. Joe. And so, but why is this important? I mean, I've talked a little bit about our evidence base, and we're now calling that as evidence-based medicine at the deep end, because there's loads of evidence-based interventions that our universal healthcare system pays for patients, but our patients can't access, and that varies from diabetes education to remission, pulmonary cardiac rehab, talking therapies that were designed for highly health literate people who could do all the homework with CBT in their 6 sessions and suddenly miraculously were better from depression and anxiety. It's just not the patient groups that we're seeing. And even cancer screening programs. In the UK, we sit on a cancer screening rate that's around 49% for ethnic minority populations, about 56% in the most socioeconomically deprived decile, and goes up to about 70 to 80%. Now, if I've been sitting on that screening program for the last 20 years in the UK, I'd be wanting to ask the question about who was it working for, since, for example, colorectal cancer has a higher prevalence and worse outcomes in precisely those populations. Next slide, please. Research matters. Even taking the example of mental health, and I'm quite sure that in Canada you probably have the same issue with people who don't fit in the box, sort of being bounced around in between the system. And the wonderful Heidi Pickett describes this as the bridge of access, where gaps in knowledge cause gaps in the bridge. It costs about £1,200. I don't know what that is in dollars, but it's a lot of money in this country for a full course of talking therapies. But in deprived areas, patients referred for this therapy are less likely to be actually taken on for treatment. So I don't begrudge middle class white people getting really good psychological therapies, but I do ask the question about why this isn't available for all, that kind of mental health support. Next slide, please. Some of the practicalities, we set up a cluster of 9 practices, 68,000 patients, open for business for studies that were funded by our National Institute for Health Research. That brings resources into the practice to support recruitment. But unfortunately, all the studies were sort of culturally incompetent, set for the health literacy of a graduate, etc., etc. As David has just described, though, our NIHR has pivoted a full turn, and now they will not fund stuff that isn't going to be inclusive by design, designed with and by patients and practitioners. We set up the first patient and public involvement group in England from deep end areas. That's still going strong. We had a bit of a lull post-COVID, where practices were really struggling with the workload, but that started to rebuild. Next slide, please. And now we have what we describe as a sort of 3-part collaboration: patients and communities, researchers in a connected academic unit, and clinicians. And we want to co-create useful, relevant research. And we've done lots of research studies. We have had loads of funded fellowships because we can access funded fellowships. And we've also found and sought out a talented bunch of early career researchers who, when you say there's no reason why we shouldn't be recruiting from underserved populations, just roll their sleeves up and get on with it. We did find from the early studies that we designed from our academic unit that we could recruit people from the most deprived areas, but we couldn't recruit people from racialized minority populations. Next slide, please. we've written about trust, but we also reflected, because we feel that's an us problem and not a them problem. We referred to Sherry Arnstein, who's a wonderful woman. If anybody wants to read, her short 2 or 3 page biography, we used and adapted her ladder to understand citizens' participation. We use that as a training tool and a reflective learning tool within our research team. And we've moved gradually up into the green zone, and we've done that by working with community research link workers who work within our healthcare teams, supporting recruitment, co-analysing and interpreting results. Next slide, please. And lo and behold, we've found that we're only limited by our ambition. We've done loads of highly relevant research through our DPEN networks, working with collaborators. And as David said, we've had a rapid increase, partly because the funding structures in England have allowed pump priming support for DPEN practices to get together and say, we're open to do research with and by patients. And these are just some of the studies that have come out of the University of Sheffield and Keele University, where I am now. Next slide, please. In fact, I can't fit all the topics on now with the free software. So I'd like to conclude. There's 2 QR codes here. On the left-hand side, that talks about power redistribution, about researchers reflecting on their power within healthcare and research, and how they can influence equity. And that was in the British Journal of General Practice. And the one with the dinosaur in the middle links you to our DPEN Research Alliance website. And if you just flick onto the community engagement part of it, you'll see that we've developed a toolkit about working with community research link workers. And so in the end, to conclude, I think to address the inverse research law and evidence-based medicine, we need to be ambitious, excellent, redistribute power and change research culture for the better. And we've got a large number of academic researchers who've never done anything different to that. And they're learning all the time to get better. Thank you. Of course, this isn't me. We have a whole host of people, and I'm very grateful for the financial support we've had along the way. Thank you.
Hi, everyone. Both very hard acts to follow. Thank you both. I'm going to focus on DPEN Ireland, which is a little bit different to the UK groups, because our health system is so different. And knowing what the others would speak about, I wanted to focus a little bit on how we've developed and what we've achieved through both advocacy and an acceptance that incrementalism does eventually lead to results. So let me just click on. So I'm not going to go through this in detail, because you're all really familiar with the inverse care law, and it's been mentioned already, but I just want to highlight the second part of it, which is often not mentioned as much, which is that it operates more completely where medical care is most exposed to market forces and less so where such exposure is reduced. And this is particularly the case in Ireland. So we have a mixed public and private health system. Like most countries, most high-income countries, we have a crisis with GP recruitment and retention. We have a GP contract that's over 35 years old. And essentially about 40% of our population have NHS-style health care that is capitation based on age and gender, but there's no deprivation weighting to the capitation at all. So it's really, in fact, in practices where they have premature mortality, they're actually disadvantaged because they have less older patients to get higher capitation. Our national health care policy is called Sláinte Care. And as in many countries, it's all about a shift left out into the community. And there is increasingly some talk about a new GP contract, and I'll come back to that. So we began in 2012. Essentially, there was a group of GPs working in inner city Dublin, and we decided that we would meet and just informally try to share experiences. And we knew there was another GP called Adele McGinnity who wrote letters to the papers all the time about these issues. So we contacted her. We all met, and it is. I'm sure many of you had the experience of when you meet people all with the same kind of aims and objectives. It was really supportive and interesting and fun to meet with each other. And then, of course, we heard about the DPEN movement in Scotland. and we linked in with them, and we became one of the earlier Deep End international groups. Now, unlike in Scotland, because we don't have universal primary care, we actually had quite a lot of difficulties identifying who those 80 to 100 practices serving the most deprived populations were. And believe it or not, we're still struggling to do that, though it's looking increasingly like we're nearly there. So at the moment, what we have is self-declared GPs at the Deep End, and that has worked well for us, but it does need to be formally done by the health service, and that's going to happen in the next 6 months. So we have a website. I put the address down there, and over the years we've met regularly with each other. We've had a focus on GPs because that was just where we started, and we didn't feel we had the mandate to represent other groups. But we're increasingly, obviously, we're fully supportive of the idea of primary care teams and other workers. But it is an interesting issue for a group beginning, is exactly who do you represent and who do you talk about? So we had reports that we issued over the years on the inverse care law, link workers doing social prescribing. And then for the last 6 or 7 years, we kind of pivoted to look at health inequalities in children, because we have found that most people, they may have arguments about inequalities in adults, but very few people would argue that children should be treated differently. So we've had a number of submissions to various political processes, and we've had meetings with people running the health service and with politicians, particularly around this policy Sláinte of Care that we had some input to, and adolescent mental health services, child and adolescent mental health services, and mental health. And we've been really, really glad to have the international links that we've had. From the very beginning, we agreed on our policy recommendations. And while we may have been boring ourselves, saying the same thing over and over again, we were usually saying them to people who hadn't really thought these things through before. So we wanted the government and the health service to support fully functioning primary care teams in disadvantaged areas. And we went through a really significant period of economic austerity where there was an embargo on recruitment. And we were saying, well, you should lift the embargo in those areas. We wanted a very strong primary care infrastructure, and we still talk a lot about that. We have a system in Ireland that is called DEIS schools. It's an Irish word. And essentially, they put extra resources into primary schools in really disadvantaged areas. So there was a model in place that we said, well, why don't you do a similar thing for health? And of course, that would mean giving GPs more supports, more consultation time. We're really pushing for deprivation weighted capitation payments, but at a level that will actually make a difference. There's an acknowledgement, a lot of debate about salary GPs in Ireland versus independent contractor GPs. And it's certainly the case that probably you need some salaried GPs to support these types of practices. And they also need obviously additional nursing and admin time and all the other kind of primary care supports that could be offered. And we also were often pushing for improved access to diagnostics and other secondary care services. Because our patients had no opportunity to jump waiting lists and pay out of pocket for some of the, like if they needed a scan or ultrasound or whatever. Now, interestingly, because our system is so mixed up in terms of perverse incentives, since COVID, the government have been paying the private sector to provide diagnostic services to the public system. So ironically, we now have access to those things, but it's not a sustainable system for our healthcare service. So I'm just going to focus a little bit on advocacy and how we have managed it. And what we have learned over the years, and if you look at the literature on advocacy, our experience has kind of reflected that. I don't know if you can see the little picture there. It depends on whether the faces are popping up in your way or not. But that's a little diagram that Adele McGinnity draws. And we bring this in on coloured paper every time we meet these politicians or other people. And we explain the inverse care law using this picture. So it's not only that there are less practitioners in a disadvantaged area, but the people are sicker. So it's a kind of a double whammy. We talk about the data largely from Scotland because we don't have the same quality of data in Ireland about multimorbidity developing 10 years earlier, the later cancer presentations and higher mortality. And then if they don't even care about any of that, they usually sit up and listen when you talk about the fact that the people on hospital trolleys, which we have a huge problem with because we don't have enough beds, are largely coming from communities with higher rates of chronic conditions, and that about 10% of people with 4 or more conditions account for 34% of emergency admissions and 47% of preventable admissions. And then they suddenly become very interested. When we talk about advocacy around data, we have this series, and I think most countries have these are kind of area level maps based on deprivation formulae. And this is Dublin. And the dark blue is the affluent area. So you can see the south east part of the city is very affluent. And then the darkest orange are the most deprived areas. And one of these areas that's in the northwest of the city, called Blakestown, has a cancer mortality rate of 381 per 100,000. And 5 kilometres down the road in Castleknock, which is one of the blue areas nearby, it's nearly half that at 128 per 100,000. Now that's old data, but these differences still exist. But data on its own is not enough. So we also present them with case histories, because this is sometimes when the numbers come, people can be a bit overwhelmed by, I think sometimes by health inequalities data and premature mortality. And, you know, it doesn't ring home until they think of an individual. And one of us speaks about this. It's a kind of obviously a anonymized patient, 53-year-old woman, to be very familiar to any of you working in clinical practice. She's got chronic lung disease, diabetes, depression, and severe eczema. She's got a 14-year-old son with behavioral problems about to be expelled from school. She's smoking. Her diabetes is not controlled. She's got a chest infection and a flare of eczema. And Adele, whose case this is, takes you through this whole consultation. And at the end of it, they realize she's due her cervical check for cervical cancer screening. And neither the patient or the doctor have the energy or the time to do this. And that's why there's later cancer presentations in these areas, because the doctors are overwhelmed and the patients are overwhelmed dealing with the day-to-day crises. And I'm very happy to share slides. I don't have time, but this is actually a video of Adele telling the story. And she actually did this on national television and won an award for it. She's a very articulate GP. So if anyone wants, either email me or I'm happy to share slides and you can have a look at that. For example, sorry, I won't do that now. This is another picture. This is again through our focus on children, and it's a visual representation of the chaos that happens. Parent brings a child in to see the GP or a public health nurse who's distressed. And there's just an array of services chaotically funded by the public system, though they are mainly NGOs. Lots of barriers, particularly in the child and adolescent mental health services. You essentially nearly have to go through an ED to get into those services. And in many very disadvantaged areas, a lot of the services for families are actually only open to those children who are now in statutory care because they're so overwhelmed. So I'm nearly there now. And I mean, what I would say is that while we've been at it for over 12 years, these are the successes that we've had by simply plugging away at it. It's the deep end idea. When you start to hear people talk about the deep end, you know that you're getting somewhere because it's a concept that's coming through. We did have our first ever success in terms of there was an amendment to the GP contract in 2019, and they included, it's really a paltry sum for a health service, 2 million, that was to be divided out amongst GPs in deprived areas as a special grant. It's now 3 million, but what they did, it was so interesting. The union decided that it would be better if more people got some of it, and they've now diluted it down to about 300 practices. Now that is about to change because the health service planners are about to identify the practices that should be getting it. And it'll drop down to 100 practices, and then it'll actually be an amount that will allow you to employ somebody to work in the way your practice needs and your patients need them to work. We also had a grant overlapping. We don't have a distinct research network, but we're going to build one up inspired by Caroline's system. But we have run a trial through Deep End Practices. We had a grant for that. We had a GP fellow for a year who was able to look at the impact of the grant and what the practices were using it for. And then through our links with Deep End in Scotland, we were having a meeting with, some of you may have met Kerry Lunan along the way. And she just said, oh, why don't you put a business case into the Department of Health? And we happened to be meeting the Prime Minister because he is a constituency politician, and one of the GPs in our group was in his constituency, he was centre right-ish, and he knew that the left parties were chasing him in the next election, and he set up a child poverty unit, which is a great thing that he did. But what we said, we would meet him on that basis, and we just said, oh, is there any chance you give us some money? And he gave us €300,000 for 3 years, and that has been a game changer for us, because we now have an academic lead who's Patrick O'Donnell in Limerick, and a GP clinical lead, Breed Shanahan, a GP in Dublin 1. And then on the back of that, we've also got additional funding for them. It's a very interesting project on looking at menopause in deep end practices, because as everything else, there's far less HRT and menopause care happening in deep end practices. So to conclude, the fundamental issue is resources, and we need allocation based on need. And I don't think there's a system that has cracked that, though some are better than others. Even Denmark has a deep end group, though they've got way more resources than the rest of us. It's critical that we target for benefit, and we keep emphasizing to decision makers that it's also more efficient to do this properly, as well as ethically and more equitable. The other thing that we do need to emphasize a lot, because what we're finding, and I'm not sure if this is the case in Canada or in the UK, is there's been quite a growth in the area of inclusion health. So that's like street medicine, homeless health, migrant health. And we're seeing that people are thinking, oh, that's not our problem, that's inclusion health. Whereas we're saying that general practice in disadvantaged areas, it's about poverty across populations and addressing the need of people who have higher health problems. And of course, we really, really need data to support policy and planning. So our current aim is to try and get our government to agree to set up a national health inequities strategy working group, because they had one for women's health and it was really successful, and it brings in all government departments, and we would like them to do the same to address health inequities. So thank you very much, and I'd be very happy to join a panel and a discussion now. Thank you.